Okay. Break until I will just show you the rest of cases. So we find this with just a few slides and we finish this one. So what do you think about this one? Yes. Yes. So this coalition, why you mentioned that it's coalition? And you mentioned that it is calcaneonavicular. Yes. So what is coalition? And why you mention it like this? Marwa? Yes, Marwa. Nice. Yeah. Bony type and with this appearance is anteater appearance or anteater sign. So you are talking about coalition. Sometimes it's subtle and sometimes it's not bony type. So it is a bit difficult, but here is one is classic. So this is the tarsal coalition, calcaneonavicular. It happens when you find the young patient. So when you find X-ray of young patient and you it looks like a bit normal, search for coalition. Maybe you can find something like this. And this is a cause of pain in young. So when you find it with this anteater nose appearance, so you are talking about calcaneonavicular coalition. There is other type of coalition which is talocalcaneal with C sign and tailor peak, right? So this is what is called talocalcaneal coalition with C appearance, C sign, and this tailor peak. Okay. Yes. Talocalcaneal coalition. Yes. C sign. So what do you think about this one? No. Yeah, maybe one of the good differential myositis because it is like soft tissue. Nice. So yeah, no, not fibrous, but okay. Let's go to something very new, not very new, but yeah, geographic lesion with well-defined and sclerotic margin. So this is what's called Myxofibrous tumor, liposclerosing Myxofibrous tumor. The differential will be fibrous, perfect, intraosseous lipoma, infarct, myxoma. So it is not myositis ossificanis. Yeah. Yes. So it is a bony lesion with well-defined sclerotic. Yeah. So this is what is called liposclerosing. Sure that the most important to mention the diagnosis. He mentioned, sorry, the differential diagnosis. It will go with infarction, yes. Bone infarction, maybe fibrous, maybe lipoma, maybe myxoma. Not common in the exam, but okay. No, very rare to see even, but okay. Okay. We mentioned this one about the types of femoroacetabular impingement, which have cam type and pincer type, right? And this, when you find the junction between the head and neck, is foreshortened, and there is two types. This one with the, yeah, when you find the cam type, which is non-spherical femoral head, or there is bulge of the bone in the anterolateral head neck junction. Yeah, when there is over coverage, this is the Pincer type, right? And when you find the bump sign, or this is the, yeah. Which type is this one? This is the over coverage, right? So this is the type of over coverage, the Pincer type of femoroacetabular impingement. Yes. So this is the cam type. When you find overgrowth of the femoral head neck junction, the alpha angle will be elevated, and you will find like this bump sign. Yes. The Pincer type, which is crossover sign, like this one. Yeah. And you will find the anterior margin of acetabulum projecting lateral to the posterior margin, like this. Okay, so this is the what is called Pincer type. It is not cam type. And there is one type is called mixed type, which is between both. Yeah. So this is what's called crossover sign or cam type. So this one is the Pincer type. We showed this case before, but in this one it is the Pincer type. Yes. The normal one, the Pincer type, the cam type. So here, when you find the over coverage, this is what's called the Pincer type, like this. And when you find the bumpy appearance of the femoral head, so that is what's called the cam type. Okay. Sometimes in the exam, they can show you like old age with osteoarthritis, and this is more difficult when you saw this with osteoarthritis. So post impingement, what happened? The osteoarthritis happened. So in this case, it will be more difficult because you will think just about osteoarthritis, but you will not think about the cause of osteoarthritis, which is the impingement. Okay. And this is what's called alpha angle. And there is some details about this, but it is not our target in this presentation. So let's go to another aspect, which is the lateral talocalcaneal angle and the Bohler angle. Yes. So what it is? What is the importance of Bohler angle? Yes, the calcaneal fracture, to know the calcaneal fractures. So when you find, yeah, normal it is between 20 and 40, and you should measure it like this. Sometimes when you see the calcaneus and you don't see any abnormality or maybe subtle abnormality inside, so you should think about the Bohler angle and you measure it by your eyes. And sometimes there is calcaneal fracture, okay? There is some details about this. Let's, okay, this one is antimony case with this, what's called Madelung deformity. Why is Madelung deformity? Because there is, yes, this appearance with the distal radioulnar joint and the deformed aspect of, yes, deformed aspect of distal radius and also ulna, yeah, medial epiphysis, okay, yes. So this what's called Madelung deformity, and there is differential, very nice differential about it, either infection, post-infection, or post-traumatic, which is the common real practice. But also don't forget the something congenital like Turner, or bony lesion like osteochondroma, or the mucopolysaccharidosis, yes, Haglund syndrome. This one is a bit tricky, come to you in the short cases. And yes, there is what's called pseudo-Madelung, okay. What about this appearance? When you find this edema in front of the, in front of the tendo Achilles, and this is what's called retrocalcaneal bursitis. When you find this retrocalcaneal bursitis, so this is what's called Haglund Syndrome. This recess, you find like edema, and there is some bursitis. Also, you find like some tendinopathy, and with there is marrow edema in the corresponding aspect of the calcaneus. So when you find this 3 stigmata, bursitis, tendinopathy, and maybe some edema in the Achilles, so in the calcaneus, so that is what's called Haglund, right? And let's end with this one, which is a bit antimony. Okay. So what happened here? This one should be the nerve, which is passing here in the wrist cuts, in the, so what it could be, this is like antimony case, especially if he show you this big hand with big fingers and big everything, okay? So that's what's called Macrodactyly, and it is something syndromatic. So you will talk about the congenital aspect, all the congenital aspects, and it is associated with this one, what is you mentioned, it is fibrolipomatous hamartoma of the nerve. So it is congenital, just something to know. Okay, all this we will share just these cases, and in the Radiopedia slides, okay? So you can have it in any time. I hope it can be helpful. Let's now go to the 3 cases, which are interesting cases, and finish the session for today, okay? So this case Yeah, what do you think about this case? So when you find this appearance, this one is a bit study, and the tracer here is what's called sodium fluoride. And this sodium fluoride is to see the uptake in the bones. It is more better in bone scan, the conventional bone scan, to see the metastasis. So sure that you will ask me about the history. So this patient is 65 years old, postmenopausal woman, and she have recurrent right breast cancer. And she referred to do what is called sodium fluoride PET-CT, okay? They find something in the sternoclavicular joint and they want to rule out if there is any metastasis. This patient was in hormonal treatment and alkaline phosphatase was normal. So if I can ask you like side question, what does this mean? Like if it is here alkaline phosphatase is normal, yeah, why? What should mean? Yes? Yeah, to say that is like the hyperbara is, yeah, is not hyperbara. So let's go to the image again, and maybe you can see this tracer uptake here in these joints. So this one is arthritis, okay? And you will check for the sternoclavicular joint here, okay? So what? Let's think. Do you see anything abnormal? Sure that you will look for the asymmetrical uptake, and you will check because this cancer is breast cancer. No, it is PET scan, okay, for sodium fluoride tracer, which is for bone metastasis. So just we want to check what is in the bone here, could be like a metastasis or not. So let's have a look in the other images she have. So she did CT and they concentrate in something here in the CT, and they show you in the PET-CT that there is high uptake in this region. So what do you think about it? Nice, nice, perfect. So this is what's called hyperostosis frontalis, yes. And as you see, it can take uptake, and even it is benign, it can show uptake, yes. So sometimes, yeah, if we choose this hyperostosis frontalis, so show the correct answer. Yes, it is true. And what is the image finding in this case? So there is right sternoclavicular joint increased uptake. And also you can see that there is multiple vertebrae and in the joint space, which is consistent with degenerative and arthritic changes. And there is symmetrical thickening in the frontal, which when we see the uptake and the appearance in CT, it is more characteristic to be hyperostosis frontalis interna, yes. And this patient, even if he have cancer breast, but when you see the image of the CT and you know it, like antimony case, so it's easy for you to detect that it is not something malignant, it is benign lesion, okay? So just sometimes it is false positive to mimic like something metastasis. Okay. Another case. So this appearance, before I go to the history and everything, this is like a selected image of CT. And what you can describe in this patient, try to describe. I'm sorry that I think that I choose this images. This case is sorry in the end of the session and everyone is sleeping. Okay, so good thinking that with this appearance, maybe we can think about Paget, fibrous maybe with this ground glass, but something like important to see that the fat in this patient is abundant, right? And the muscle is like atrophied. So that's why you are thinking about that maybe he's a bit old, right? And there is something going with this appearance. So before we continue, maybe we can go to the history and try to find something in the history of this patient here. This patient is 73 years old male with coming the internal medicine department, and that he have anemia, and there is some inflammatory markers. Yes. Gastroscopy and colonoscopy, bone marrow aspiration, nothing suspicious. So he did FDG PET-CT. Okay. So you are going, all of us going with Paget. Do you like to choose Paget or you have other choices? Idiopathic fibrosis, Langerhans, or Erdheim-Schister? All agree with Paget? I want someone to talk because I feel that everyone is sleeping now. Please, you can share with voice now, it's better. So Dr. Nirmin wanted to, no, you have one choice. You don't have, you cannot, it is a single best answer. So you cannot put more than one choice. So what would you like? Okay. Erdheim-Schister, sure. Okay, let's choose Erdheim-Schister. So before we continue, so let's have a look in the CT better and choose. Okay, well, we have like arrows here. This is the sternum, and there is something soft tissue here behind the sternum, right? And yeah, this is the aorta, and you cannot even see the aortic boundary clearly because there is a soft tissue encasing the aorta. Okay, I will return to choices, but I won't show you all the images. And the MRI brain, okay, this one is diffusion, and there is something going here. It's a bit difficult now. So how you collect this finding? So before we go to the, yeah, you want to check the kidneys, okay? But the kidneys, it doesn't appear in this selected image. Ala, do you see any, okay, why Erdheim-Schister, why? Why? So before we go to the final diagnosis, let's try to collect the image finding we find. Anyone before we show the answer want to tell anything? Hostiocyte infiltration, you mean Langerhans? So why Langerhans? Okay, no iridium. Let's go to the image finding and see. Okay, so this CT image, we mentioned otosclerosis and cortical thickening, and what that's we take this mark. Okay, so we take mark here, good. It take the diaphysis, metaphysis, okay. The image of the corresponding FDJ uptake, there is high uptake. Okay, so already we are going well until now. The image of the thorax and the abdomen show that there is soft tissue infiltration around the aorta. So we take 2 marks until now, good. And it go in the left and right paravertebral space, nice. There is retrosternal soft tissue infiltration, perfect. So we take 3 marks, nice. We missed this. Adrenal gland are swollen with soft tissue infiltration of the adjacent fat. Wow. So let's have a look in this. And there is increased FDJ tracer in the adrenal glands around the aorta in the stomach. And there is something about the kidney. So before we continue, let's see, maybe we don't have this image. So, sorry. Okay. We have this image in B, yes. Okay. So here and here, okay, this soft tissue, and when we go down, we can find that the adrenal glands, okay, have this appearance, and in the tracer uptake of the FDJ is high in the stomach also, yes, and the adrenals is high, and surround the aorta is high. So, and if we go to E, then you can find around the kidneys, yes. So I think now is more easier to tell the final diagnosis with the collection of this. So what it could be, and what about this brain image? Let's have a look in this one. Yeah, it is Erdheim-Schuster probably. Let's have a look in the image finally to collect the data. Yeah, so we mentioned that there is soft tissue infiltration in the perirenal, pararenal, which is called hair kidney sign, and extended to the renal sinuses. And there's hypermetabolic spot, the anterior middle cerebral artery with FG uptake, and there is no corresponding lesion in CT. Okay. Okay. So so the correct answer will be Erdheim-Schuster. Let's have a look in this. Yes, this is the single best answer. We choose it, and it was fine. Let's have a look in what is Erdheim-Schuster. It is like multisystemic disease, and it have osseous infiltration, extraskeletal involvement. It can have bony pains, diabetes insipidus, and many things. The osseous infiltration, bilateral otosclerosis in the metaphysis and diaphysis of long bones. Sometimes it have cortical thickening, narrowed, and so on. Yes. The most important, and this what's called the hairy kidney sign. This is the key in this case. When you find the perirenal and pararenal space infiltration, and yes, this is what is called. Yeah. Sure that lymphoma will be one of the good differential in this case. Cardiac also involvement can be happen. Okay. Pericardial effusion, pseudotumoral mass, retroorbital. Okay. It is a bit tricky, but it's good to know. In the FDJ, as you see, it show high uptake. That's why it is in the. It will be a bit difficult to differentiate with lymphoma and the other lesion that cause high uptake. Sure that the biopsy will be the best solution for this. Okay, and confirmation by biopsy. They don't have the medical options here is not high. That's why in lymphoma, if you diagnose lymphoma, it will be you can have a good option for treatment, but this is not. Let's go to the third case. We have just 6 minutes to finish this session. So this patient is 76 years old with right upper lobe squamous cell carcinoma. And just I want to make, yes, how to, what is, yeah. So you have this appearance and you have this history, right? Anyone is still awoke or we, yeah. Okay, 76. So what it could be, yes. Why elastofibroma dorsi? Let's have a look in the axial view. Yes, typical appearance on the CT and typical location, and uptake is less, yes. So you are dealing with elastofibroma dorsi, can have some uptake, but sure it will not be the uptake like the tumor, the right upper lobe tumor squamous cell carcinoma. And you have it bilateral and in typical location, especially with CT is more easier to know about it. So sure, if you choose elastofibroma dorsi, it will be the, yes. Also the location deep to the serratus anterior muscle, latissimus dorsi, the attenuation, yeah, and make the metastasis diagnosis is not typical in this case. I hope everyone is enjoying, and sorry for the, we try to make it shorter. I think we, through the 3 sessions, this one was the last session for the MSK. And I want to ask you if you want to continue in another system like chest or GI, abdomen, or whatever you like in the same system. So, okay, chest, Nirmin, okay. So you, what do you like? Maybe you can discuss this in Telegram. Everyone want to vote in Telegram better, and the 2 sessions per week, because there is maybe some people who have exam soon. You want to make it quicker review, but the issue that, yeah, 2 sessions a week. The issue that the slides, yani, need to cover much cases, especially in the MSK and neuro, and this, it was needing, you need like much cases to cover, yeah. So one quick review, maybe in the end before the exam we can make one quick review, but until we cover all, I think it's better to continue in and finish the most important, like antimony and short cases. So, and I want to ask you, continue again in the English mood, or is fine with you, or to change? If they have any suggestion, we can just send me. I hope everyone is doing well, and inshallah. Okay, English, okay. Mixed, okay, English, okay, English, okay. So maybe, okay. So inshallah, have a nice day. And what about the day we can choose? Is it Monday or Wednesday? The second session, Monday or Wednesday? Okay, any? So because I know that there is much webinars in this season, so I know that many webinars. I don't want to choose like day that someone have webinar. I know that maybe in Tuesday there is some webinars that are useful for you, so better to be away from Tuesday. So in the Telegram group, we have the Telegram group and the YouTube channel. If you like to send comment in the Telegram or here, we can inshallah discuss together. Okay, maybe in Wednesday. inshallah, Wednesday, and we will send the link in the Telegram, inshallah. And I think at the same time, and maybe the chest, inshallah. And see you, inshallah, soon. Thank you, and Assalamu alaikum.